Okay, so let's talk about something that's highly tested, and that is differentiating between Lambert Eaton myasthenic syndrome versus myasthenia gravis. Now, the first way that exams will try to trip you up is by referring to Lambert Eaton or LEMS as just myasthenic syndrome. Myasthenic syndrome. And what the exam makers want you to do is they want you to think of myasthenic syndrome as myasthenia gravis, when in actuality, it's not. Lambert-Eaton myasthenic syndrome, aka LEMS, is also referred to as just myasthenic syndrome, whereas myasthenia gravis is just myasthenia gravis or MG. So that's the first way exams will trip you up. Next, to really learn how to differentiate the characteristics between these two diseases, we first need to talk about normal physiology and how an action potential travels from the presynaptic to the postsynaptic muscular fiber. So, in normal physiology, the way it works is that the presynaptic motor neuron will have some sort of electrical impulse that comes down and it's going to open up a calcium channel on the presynaptic motor neuron. The calcium channel opens, calcium is able to come into the nerve terminal. In the nerve terminal, acetylcholine is able to be dumped into the neuromuscular junction, and in the neuromuscular junction, acetylcholine is able to travel and bind to the acetylcholine receptor on the postsynaptic muscular fiber. After binding, nerve conduction can go down the muscular fiber. And so that is how normal conduction works. Now, in these disease processes, different receptors are being blocked. So let's talk about Lambert-Eaton myasthenic syndrome. So in Lambert-Eaton, the receptor that's being blocked is the calcium channel on the presynaptic motor neuron. The calcium channel is blocked, it prevents calcium from actually coming in, and because calcium is unable to come in, you no longer have that release of acetylcholine. So that is how Lambert-Eaton works. There are antibodies that block the calcium channel. Now, in myasthenia gravis, the receptor that's being blocked is the acetylcholine receptor on the postsynaptic muscular fiber. Again, on the postsynaptic side. And the way that that works is in myasthenia, calcium is able to come in a-okay. Acetylcholine is able to be released into the neuromuscular junction, but it's unable to bind to the acetylcholine receptor. And the reason why is, again, there are antibodies that are blocking this receptor. So again, in Lambert-Eaton, it's affecting the presynaptic calcium channel, and in myasthenia gravis, it's affecting the postsynaptic acetylcholine receptor. Very, very important to memorize that. Next, exams will also ask you about differentiating characteristics between Lambert-Eaton and myasthenia gravis. And so initially, just to put down a little bit of a framework on how to memorize this information, I first look at the names of the diseases. And the way I think about it is that myasthenia sounds more like a woman's name or a female's name, and Lambert-Eaton sounds more like a male's name or a guy's name. So from there, I just say that myasthenia gravis affects women more often than men. This is not to say that it only affects women, but that women are affected more often than guys. And Lambert Eaton, the opposite is true. Lambert Eaton sounds more like a guy's name. Men are affected way more than women. It's great. Next is exams will always, always, always test you on which condition gets better or gets worse with repetitive use. And in Lambert-Eaton myasthenic syndrome, it gets better with repetitive use. Whereas in myasthenia gravis, it actually gets worse with repetitive use. And why is that? Well, in myasthenia gravis, again, we know that the postsynaptic acetylcholine receptor is being blocked, acetylcholine is unable to bind, and every time that the muscle is being activated, each time the muscle is being activated, less and less and less acetylcholine is able to actually get into this neuromuscular junction. And because there is less and less acetylcholine, there is less and less acetylcholine to actually compete with the antibody. And so your muscles are just going to get weaker and weaker. So again, myasthenia gravis gets worse with repetitive use. The next thing that exams will ask you about is about muscular pain and reflexes. Now, the way that I think about this is, again, Lambert Eaton to me sounds like a guy's name, and I imagine a really, really buff guy that goes to the gym often, extremely bulky guy, and because he goes to the gym often, he has more muscular pain. And because he's so bulky, his reflexes, well, they are decreased. He has decreased reflexes. For myasthenia, how I think about it is I imagine a woman who plays tennis. A woman who plays tennis. And because she plays tennis, her reflexes have to be pretty sharp. So she has normal reflexes. And because she doesn't hit the gym as much as this guy does, she has no muscular pain. So that's how I think about that. Lambert Eaton, you have muscular pain and you have decreased reflexes. Myasthenia gravis, you have no muscular pain and your reflexes are normal. The next thing is Lambert Eaton characteristically presents with proximal limb weakness, so thigh and arm weakness, and you also have autonomic syndromes. So, autonomic symptoms such as decreased blood pressure. That is highly, highly tested. Autonomic symptoms, you remember that it's referring to Lambert Eaton. Myasthenia gravis, however, presents with bulbar symptoms. So what is that? And that's difficulty swallowing, difficulty with speech, and what's highly tested is respiratory weakness. What's important for people who are in the world of anesthesia is that patients with myasthenia gravis may have to be kept intubated after a procedure because they have baseline respiratory weakness, unless unless these patients have well-controlled myasthenia, unless these patients are on pyridostigmine and are being treated. If they are untreated, they're more likely to have great respiratory weakness and are less likely to be extubated after surgery. So that is very, very important to remember. Again, autonomic symptoms and proximal limb weakness is Lambert-Eaton. Bulbar symptoms and respiratory weakness is myasthenia. Next are two different cancers that can be present. So in myasthenia gravis, thymoma Thymomas are more likely to be in patients with myasthenia gravis, and the way I remember it is the word mom and thymoma referring to myasthenia. And then for LEMS, the disease with a lot of letters, it is associated with small cell lung cancer, which is also a lot of letters. And so that's how I remember that. Small cell lung cancer attributed to LEMS, thymoma attributed to myasthenia gravis. And the last thing is treatment options. What's really important is pyridostigmine is used to treat myasthenia gravis. You will always be tested on that. Um, and you can also excise the underlying thymoma, so thymectomy. Whereas in Lambert-Eaton, you want to treat the underlying cancer, and that is most likely the small cell lung cancer. And that can be done with radiation, certain types of medications. Now, the medications that would be used to treat small cell lung cancer aren't typically tested on your exams. The only medication that is really tested is pyridostigmine, and that is to treat myasthenia gravis. Now, the last thing that I want to talk about, and this is again more relevant for people in anesthesia, is that there are two types of paralytic agents. There is rocuronium and succinylcholine. Rocuronium is a a non-depolarizing neuromuscular blocker, whereas succinylcholine is a depolarizing neuromuscular blocker. So depolarizing neuromuscular blocker means that it actually needs to bind to the acetylcholine receptor, leading to a depolarization of the nerve fiber, and that's how that induces paralysis. Whereas rocuronium is a non-depolarizing, as in it does not depolarize the muscular fiber, it just blocks the acetylcholine receptor. So in these two conditions, the different medications will have a certain level of sensitivity or resistance. In Lambert-Eaton, Lambert-Eaton is sensitive to both ROC and SUX, which means paralysis from these two agents is actually just increased. They are more sensitive to ROC and SUX. However, patients with myasthenia gravis, they are resistant to ROC. They are sensitive to ROC, but they are resistant to succinylcholine. Sensitive to ROC, meaning there's increased paralysis. Resistant to SUX, meaning you may not get the level of paralysis you want with a standard dose of SUX. You may need to give even higher doses of succinylcholine in order to paralyze a patient with myasthenia gravis. And why is that? So again, this is probably going to be tested as well. And let's just quickly draw are pre and postsynaptic. This is your neuromuscular junction. And remember, the acetylcholine receptor is on your post synaptic junction. This is the acetylcholine receptor right here. And in myasthenia gravis, remember that the acetylcholine receptor is being blocked. It's being blocked by an antibody that is just sitting there, preventing acetylcholine from binding this receptor and thereby preventing a, a depolarization down this nerve. So a something like rock, the way that it works is that it too will bind to an acetylcholine receptor. And by binding the acetylcholine receptor, it is effectively blocking acetylcholine from binding to this receptor. So what you need to remember is that in myasthenia gravis, patients already have this antibody. And this antibody is blocking acetylcholine. And so patients at a baseline with myasthenia are going to be weak. They're going to be weak. Now what rock does, it essentially acts the same way as this antibody. It will also block the acetylcholine receptor. And so now patients are even weaker, So patients are more sensitive to rocuronium. However, for SUX, remember, SUX is a depolarizing muscular blocker. It needs to bind to acetylcholine in order to depolarize this membrane and then cause paralysis. But if the antibody is blocking the acetylcholine receptor, SUX is unable to bind. And so myasthenic patients are more resistant to SUX because SUX is unable to bind to this acetylcholine receptor. So that is very important to remember. And that sums up all the major things that you need to know regarding Lambert Eaton and myasthenia gravis. This will definitely get you a lot of points on your exams. Thanks.